But I don't forget his name. Is it chat? Costa. Costa. Come no, go to seat. Costa. Welcome to the department. He's just joined this president. Very intelligent boy. And we are very lucky to have him. And hopefully he'll help us taking our department forward. And you will nurture a lot of intelligent, the hardworking residents. Some of them are doing exams, some are in midlife residency crisis, some are starting with some adjustment issues that would guide everyone. वो ऑडिबल हो रहा है इसको जल्दी से देखना एक और कमेटी हम सोच रहे हैं एक हम लोग ना रेजिडेंट्स को टाइटल्स देना चाह रहे थे कमेटी वाइज we would seek the academic committee kind of thing where we get to recorded all these recording. So she's doing, so we will try is then you people will get those titles. You have to carry those. Waiting for host to start this. उसमें अगर मीटिंग to start this.
Actually वो सारे एक लॉगिन है actually वो
जनरेट हुई गलत हुई एक्चुअली पर्सनल अकाउंट से
दूसरी आईडी जब दूसरी
फैकल्टी वाले अकाउंट
सर अभी सब दोबारा शेयर करना पड़ेगा लिंक अभी जनरेट सभी शेयर नहीं करते
Are you there? Are you anyone use an API in all the groups? Whatever groups we have,
social media
How's it feeling? Are you comfortable? Yes. This is all this. All this. All this. All this. उसको वायर कौन सा
टाइप करके इसको नीचे रख
ये सब नहीं We'll start looking going.
Good morning, everyone. Today I am going to present a seminar on examination of gastrointestinal system. My moderator is Dr. Sanjeev. We'll start with the examination of oral cavity. A tongue depressor and a pair of gloves are necessary for examination. First, we'll check the hydration status and we'll look for any bad breath. Sweet smell is an indication of severe hepatocellular disease. A putrid smell is an indicator due to anaerobic chest infection with large amount of sputum. Fishy ammonia smell is seen in uremia, and a sickly sweet smell or a fruity smell is seen in diabetic ketoacidosis. Then tongue. Ask the patient to stick out their tongue and inspect for leukoplakia. It is a white color thickening of mucosa of tongue and mouth. Glossitis. Glossitis is smooth erythematous enlargement of tongue, and it indicates nutritional deficiency of iron, vitamin B9, B12, and is also seen in alcoholics. Candidiasis, creamy white curd-like patches, which is caused due to alcoholism, faulty oral hygiene, diabetes mellitus, and also due to use of broad-spectrum antibiotic, which cause decrease in normal oral flora. Geographic tongue. This indicate riboflavin B2 deficiency. Lingua nigra, black tongue can arise from bismuth compound or any from fungal infections. And we have to also look for ulcers due to trauma or infection. A thickened tongue with bacterial debris and food particles is common in smokers or people with respiratory tract infection. Teeth and gums. Nicotine staining is present in patients who smoke. And gum hypertrophy may be due to smoking or long-term use of drugs like phenytoin, phenobarbital, or scurvy due to vitamin C deficiency. Lips. Look for angular stomatitis. This is cracked at the corner of the mouth, and it indicates nutritional deficiency due to vitamin B6, B9, B12, and iron. Abdominal examination. We divide the abdomen into 9 quadrants by 2 horizontal and 2 vertical lines. The vertical lines are drawn by joining the mid-clavicular point to the mid-inguinal point, and the horizontal line, the upper horizontal line, is drawn at the lowermost bony point of the rib cage, usually the 9th and 10th costal cartilage, and the lower horizontal line is drawn at the upper border of the tubercle of the iliac crest. The upper horizontal line falls at the level of body of L3, and the lower horizontal line falls at the level of upper border of L5. Clinical examination. Clinical examination, inspection, palpation, percussion, and auscultation. First, inspection. Introduce yourself to the patient. Take verbal consent. Patient should lie flat on his back with legs extended, and examiner should stand on the right of the patient. Then expose from Xiphi sternum to symphysis pubis. First, we'll look at the contour of the abdomen.
We welcome Dr. Abhinav. Welcome. So, we can actually doing some basic. So we are doing some basic journal purposes for examination students, because in long cases they are asked about the system. So we plan, and then we do it in presence of faculty from medicine side, because we have our own knowledge as zero to time. So we just started.
In inspection, we'll first look at the contour of abdomen. There can be generalized fullness or distension, which may be due to fluid, feces, fetus, or fat. There can be localized distension. Localized symmetrical distension is seen in small bowel obstruction, and localized asymmetrical distension is seen in gross enlargement of spleen, liver, and kidney. Scaphoid abdomen is seen in advanced stages of starvation and in malignant disease. Movement of abdomen. The 3 movements which can be seen in abdomen: respiratory movement, peristalsis, and pulsation. Normally there is gentle rise in abdominal wall during inspiration and fall during expiration. Movement should be equal on both sides, and absent abdominal wall movement is an indicator of peritonitis, and in diaphragmatic paralysis, abdominal wall rises during expiration. Peristaltic movement normally not seen, and if seen, they strongly indicate intestinal obstruction. For example, in hypertrophic pyloric stenosis, peristaltic movement from left hypochondrium and epigastric region to right lumbar region is seen. Pulsations. Normal pulsations are not visible over abdomen. Conditions in which pulsations are visible, like transmitted pulsation from a tumor overlying aorta, or right ventricle pulsation seen in epigastrium and corresponds to apex. Then we'll inspect the umbilicus. Normal umbilicus is retracted and inverted. Distance between xiphi sternum and umbilicus is equal to distance between umbilicus and symphysis pubis. Everted umbilicus is seen in umbilical hernia or in ascites. Then we will inspect skin of the abdomen. We have to look for any dilated veins. Caput medusae are dilated veins seen around the umbilicus in case of portal hypertension. We have to look for any stria, linea gravidarum. We have to look for any old scar marks or spider hemangioma, or for any discoloration around the umbilicus or at the flanks. Discoloration around the umbilicus is known as Cullen sign, and this bluish discoloration in flanks is Gray Turner sign, and both are indicators of acute hemorrhagic pancreatitis. Then we have to look for hernial sites. We have to look for inguinal hernia, spigelian hernia, umbilical hernia, epigastric hernia, and incisional hernia. A spigelian hernia is a hernia through fascia that separate rectus muscle and the lateral oblique muscle. Then palpation. In palpation, patient should lie supine with arms loosely at the side, head and neck supported by up to 2 pillows, knees and hip flexed to prevent undue rigidity. Forearm should be kept horizontal along the level of the abdomen so that the fingers are placed flat on the abdominal wall, and make sure that your hands are gentle and warm. Steps of palpation. We will first go for superficial palpation and then deep palpation. In superficial palpation, we will look for tenderness, rebound tenderness, guarding and rigidity. And in deep palpation, we will look for masses and organs. Tenderness is pain on pressure, and it is commonly found in lesions of viscera and its surrounding peritoneum. Example, if there is tenderness in right iliac fossa, it indicates appendicitis, McBurney's point. Rebound tenderness is pain on releasing pressure. Guarding and rigidity. Guarding is voluntary and rigidity is involuntary. Guarding can be relaxed by explaining the patient that you will be careful and will try not to cause undue pressure or pain during examination. Rigidity is cannot be relieved, and it is due to underlying pathology. Liver palpation. Stand to the right of the patient. Start in the right iliac fossa and move upwards. Hand align parallel to the right costal margin and avoid rectus muscle. Hand stationary during inspiration and move during expiration. And liver moves down during inspiration, and it can be felt by the radial border of the index finger. So we will first stand at the right, to the right of the patient. We will start palpating in the right iliac fossa and then move upward with each inspiration, feeling the edge of the liver by the radial border of the index finger. Shall I call patient? If the liver is palpable, then note for the edge if it is sharp or round, surface if it is regular, well-defined, smooth, which is normal, versus nodular, which can be seen in hepatocellular carcinoma, polycystic liver, consistency, which is soft, normal, firm seen in cirrhotic patients, and hard, which is seen in hepatocellular carcinoma or in case of metastasis. Spleen palpation. Classical method. Stand to the right of the patient. Start from the right iliac fossa and go up to the left hypochondriac region. Edge of the spleen is felt during inspiration. We'll start from the right iliac fossa and we'll move to the left hypochondriac region, palpating with each inspiration. Second method is bimanual method. Again, stand to the right of the patient. In this method, the patient is put in right lateral position. Left hand of the examiner is put over the lower rib cage and the spleen is palpated with other hand. This method is used to palpate a spleen which is soft, which is very soft and not palpated by the classical method. We'll put the patient in right lateral position and then we'll palpate for the spleen in the left hypochondriac region. There is hooking method. The patient is put in the right lateral position. The examiner stands on the left side and feels the spleen by hooking his fingers over the left costal margin. And then there is dipping method. This method is used when there is severe ascites present. In this method, we will palpate similar to the classical method, except that we dip our fingers into the abdomen with each palpation so that the fluid is displaced temporarily to the side. Kidney palpation. For right kidney palpation, stand to the right of the patient. Place the right hand anteriorly in the right lumbar region and left hand posteriorly in the right loin region. Push forward with left hand and right hand moves inward and upward. Lower pole of the kidney can be felt between the two hands and can be below. So left hand push forward with left hand, and the right hand lift the right hand inwards and upward. Push forward with left hand and lift the right hand inwards and upwards. Percussion. This technique allows you to evaluate the size of some of the organs and to detect the presence of excess air or fluid. Middle finger of the left hand is placed on the part to be percussed. Slight hyperextension at the DIP joint. Blow at the back of the DIP joint by sharp wrist movement. We can hear tympanic note, which is predominant in due to gas in the GI tract. Hyper resonant notes and dull notes, which is due to organs and fluids. Tidal percussion. In tidal percussion, we will start from the second intercostal space and go vertically down. Dull note at the fifth intercostal space in the mid-clavicular line is the normal upper border. And this dullness extends up to the lower border just below the right costal margin. Normal, the span of liver is 10 to 12 centimeters in men and 8 to 11 centimeters in women. Percussion. Splenic percussion is done in trop space. Boundaries of trop space are costal margin inferiorly, sixth rib superiorly, and anterior axillary line laterally. Anti-axillary line laterally. This area should be resonant or percussion. Dullness indicate possible splenic enlargement. So this test is usually not done because it has a lot of false positive finding. This test will be positive if there is pleural effusion or if there is full stomach. This test is not usually done. And percussion by Cassell's method. Percus in the lower left intercostal space, anterior axillary line. In this space, we have to percus. This area should be resonant or percussion. Dullness indicate possible splenic enlargement. This is Castle sign. Shifting dullness. In normal individuals, flanks are resonant. In normal individual, flanks are resonant. Percus laterally from midline until the dullness is detected. Now turn the patient to left or right lateral decubitus position. The previous dull area will now become resonant. At least 1 liter of fluid is required to elucidate this sign. Fluid thrill, place the palm of your left hand against the left side of the abdomen. Ask the patient to put the edge of the hand on the middle of the abdomen and flick the finger against the right of the abdomen. If the ripples are felt upon flickering, we call it fluid thrill, and it is felt when fluid is more than 2 liters. And puddle side. This is the test that is done to detect fluid as little as 120 ml. Patient is to lie prone for 5 minutes and then goes on all 4 limbs so that the middle portion of the abdomen is dipped. Now percus abdomen, umbilicus, and now percus around the umbilicus and elucidate the dullness. Previous resonant area become dull if minimal fluid is present. Auscultation. We will auscultate for bowel sounds. Bowel sounds are intermittent low-pitched gurgles generated by contraction of muscular walls of the gut and the resultant vibration of the gut wall produced by movement of the gas fluid mixture through the gut. Normally, the gut bowel sounds are 1 every 5 to 10 seconds. Place the diaphragm of the stethoscope to the right of the umbilicus. Listen at one side of the abdomen until bowel sounds are heard. Do not move from side to side. Auscultate for 2 minutes before concluding that no bowel sounds are present. Absent bowel sound is an indicator of paralytic ileus or peritonitis, and increased bowel sounds is an indicator of intestinal obstruction. Bruit. These are variable harsh sounds due to turbulence in the arterial flow. To auscultate for aortic bruit, you have to auscultate between umbilicus and the xiphoid process. To auscultate for renal bruit, you have to auscultate 2 inches superior and lateral to umbilicus. And to auscultate for common iliac bruit, you have to auscultate midway between umbilicus and midpoint of inguinal ligament. Venous hum. Venous hum is a continuous, softer and lower pitch than bruit. It signifies portal systemic shunting of venous flow when portal flow is obstructed. It is usually heard over liver and over the umbilicus. So these are my references. Thank you.
Basically, if we asked about control of the they asked for the control of means of level so they will actually be asking them to superficial how do you deep palpation, these kind of things people are asked. Their involved sounds, at least how to visit it, where to put this. The linguistic matters, by each and every and by the pathophysiology behind each and every sign which you see there. If there is an alpha dependent in your case, it becomes sort of an gastrointestinal non-gas. Ayushi, can you stand on that side? We'll be able to see how it is. You will be able to see.
राइट साइड
नहीं नहीं सर
and we calculation of we start with the right line fossa and hypochondrial so we classify that. We keep our left hand over the left lower rib. Start calculating the left hypochondrial. Calculation of hip. We put our left hand in the left joint and right hand in the right lumbar region and we push and right hand forward.
Glute fells how we see. Liver span is also important. Also we mark this point and we further progress forward. At this point, the move is between this and this point is our for fluid change. We ask the patient to ask the patient. So we allow this present. We stick on this side. We can see the fluid over this. something else point test also. scratch test. Just like put a sign, make a noise with it. And ball sounds. If it is an alcohol dependent, supposedly, genital examination is important.
That is also part of, you can say that the patient, but that is also part of the examination. Well, we started with oral cavity. I will not that instead of examine the patient. That is also part of the examination. Sometimes skin and kidney swellings are the same symptoms. There are some points to differentiate between them. Like spleen will move with inspiration, and we can insinuate our finger under the coastal margin in case of splenic swelling. And kidney swelling will be palatable. That means by both sides, it will be by manually palatable. And spleen will have a notch towards the direction of the right highlight region. So, this can differentiate between spleen and kidney.
So pancreatitis you only share two signs. There is a hemorrhagic pancreatitis. Any other thing we can clinically say patient is having pancreatitis, specifically in our setup, we get a lot of patients and abdominal pain. आपसे मैं बात करते हैं, ठीक है ना? Thank you.
Preferred thing, the candidate like can be pain referred to the shoulder.
Yes. Generally, old age lady will send the lady to consultation. Doctor there are and then all these things need to be done. At least the patient at least a screening of GI system should be done. Not as if the patient is about to get discharged or an incidental ultrasound we find something and then we examine and then we find okay, these are the findings. We should be the reverse process. Clinical examination we should pick up the signs, then we should.
People one point you were telling about observation. Not an observation of patient lying there for like 11 days in the ward. And probably a diagnosis of sepsis, something like that. So, I think the vital sounds are actually decreased. Could you try to take from the register what to do? I know you are quite.
So it's like constipation. Like less mobilization.
So risperidone and fluzophila are very novel. We do see young kids with risperidone, chronic constipation, and subsequently going into a lot of complications, and then they have to be somehow obstructive intestinal pathology which becomes. So they were so hard that they go into obstructive pathology. Then subsequently you trace it back into the drug. All those forms of anticholinergic drugs, clopidogrel. So any other questions, comments? Dr. Meena?
Once we lost the patient because of constipation, potential complain about the problems. I think that's very important.
Why this is important is any GI issue, we send it to gastroenterologist. That should be avoided. Our own clinical discretion and taking help of medicine experts, and then subsequently going. And this is probably a public view. Gastroenterologist. It should be avoided. Before coming to sir's comments and then our invited comments, you presented well. Videos, we are seeing this for the first time in our presentation. I think the seniors did it. But this is something which is appreciated. You went through all the basics, covered most of the areas. So I think you have done a very good presentation, citing it so plus. Thank you.
I agree with Dr. that you may be practicing alone, you may be finally leaving this place and working the place. You do not have the luxury of seeking such an easy referral. So, whenever you have a cheap complaint, please do a physical examination yourself, make an assessment. Here, you can learn. What you can do is you can make an assessment. Okay, this is it. Send it to the referral and check how your assessment has been. This is one way of improving your clinical skills. Right? And we should also try to decrease the investigation because for every patient we are sending to ultrasound, and what it does is that it increases the load on the department, and then they start missing because they are doing 100 ultrasound. If you specifically also in your just instead of when you investigate sending the patient USG whole abdomen, you also write why you are sending or what you are suspecting, like pain in this region, rigidity, etc. So they will also then look more carefully at that that aspect, and you will also can diagnose the problem. So even before investigating, it should not be like just blindly we are writing USG whole abdomen, or you can say endoscopy, but you have to write your clinical impression also, like what you found in your clinical examination and why you're sending the patient. So that way also it is easier for the presentation was very good. One many commonly missed is oral cavity. Found this right. Get teeth missing, nicotine stains. So if your history of substance abuse, just to write that, gum staining, ulcer. There was Caesar patient, very strongly Caesar patient, and you haven't salmon and you see there's an ulcer in the tongue or like tongue bite. So write your findings always. Open the mouth, look, and always like that has to be there. This is a message. Covered almost everything.
So, I would request to present a moment to spare their precious time and to come here. And his presence has helped us in being more attentive. आपको सारे गैस्ट्रोइंटेस्टाइनल आपके
Thank you. Thanks for that.
That is